doctors posted there who are in full PP, that is personal protective equipment, and they screen. So we have adopted a 7-point questionnaire which is taken from ICMR. So there is a checklist. They tick all the 7 points. So you'll see the most common symptom is fever and cough. So just ask the patient that whether you have any fever and cough, or you have they have this gun to measure the temperature and ask they take the history of cough, and if there is international travel in last 14 days, or fever and cough associated with a confirmed positive case of COVID, or fever or cough. If you are a healthcare worker, they'll ask that whether you are having a fever from last 2 or 3 days and associated with cough. And even the symptoms like severe acute respiratory illness, that is SARI, which is the most commonly used. So if there is shortness of breath, the patient is tachypnic, or there is decrease in saturation, that comes under SARI. And so these are the 7 questions which people the doctors at the screening desk ask, and if any of these is tick positive, the patient is sent into the designated ward depending on the condition of the patient. So now we'll see what are the different grades of illness. So there is mild illness. Majority of people fall under this category. They just have fever around 100 to 101 degree Fahrenheit from 2 or 3 days, are associated with cough. They can also present with fatigue and malaise, with sore throat, dyspnea, nasal congestion, or headache. There is entire spectrum of symptoms. The patient may also present with diarrhea, nausea, and vomiting, or even a few studies are reported that the patient may have features of conjunctivitis. So there are myriad of symptoms in which the patient presents. And if the patient is a pregnant female, so there are certain physiological changes in pregnancy, and the symptoms associated may overlap with COVID symptoms. So we have to be very cautious while dealing with these patients who are pregnant. So if any of the doubt, they are sent through screening desk to the designated ward, and the sample is being taken, and RT-PCR is done to detect whether they are COVID positive or not. Besides this, patient can have moderate illness or severe illness. So if you to classify the disease as moderate illness or severe illness, need to check the saturation of the patient. So they have the sp2 probe. When the patient enters the screening desk, the patient is breathing on room air. So the saturation is between 90 to 94%, and patient is little bit tachypnic. Normally, we breathe at the rate of 16 to 20 breaths per minute. But when the breath is more than 24 per minute, so called to be as tachypnea. So when the patient is tachypnic with saturation of between 90 to 94% on room air, it is categorized under moderate illness. And the patient who is having fever with saturation dipping down to 90%, so or respiratory is more than 30 breaths per minute, and there is obvious distress, is called severe respiratory illness. And then they have to send it to the SARI ward where they are managed accordingly. Then these illness can lead to ARDS, that is respiratory distress syndrome, in which there are bilateral changes, acute in onset, both the lungs are involved. If we do CT scan, if we do X-ray of these patients, we'll find bilateral opacities. And if feasible, if the patient is stable enough to be sent to CT scan, so CT show ground glass opacity. So I'll be discussing few slides about the X-rays and CT images. First of all, I would like to thank the Department of Diagnostic and Interventional Radiology for the support to provide us the X-rays and CT scan of the patient in different stages. So this is very important, because we need to understand that probably many times the X-ray doesn't correlate with the severity of illness. Many times CT doesn't correlate with the severity of illness, but patient may become sick over a due course of time. So in this first slide, we'll see that this is the X-ray. Apparently, seem to be absolutely normal. Besides this few highlight shadows on the right side. So the patient was stable. They sent for CT scan. CT scan was also fine. There are on basis there are ground glass opacities found on the basis. Otherwise, majority of the sperms they didn't show any of the either patch or any changes in the CTs. So this is mild illness. Now the patient goes into category of moderate illness, that is, patient is little bit tachypnic at a respiratory rate of 24 and saturation between 90 to 94%. So again, you see that X-ray is not that bad. There is no obvious patch, except there is some haziness on the bases. Many times, when the X-rays are taken, they are bedside. So it's not possible to take a proper PA view or proper film and deep inspiration. So diaphragm is pushed up because patient is sitting on the bed or patient is lying on the bed. So diaphragm is pushed up, so you don't get a well inflated image. So probably because of that also this haziness comes on the basis. But if you see the CT scan, again you will find there are ground glass opacity, they have increased all of the scans. So the radiologists, they classify into the moderate illness in which they found opacities at multiple places. So now coming to the CT scan of severe illness and X-rays of severe illness. So the patient is at this time is severely ill. Still, X-rays is more or less clear. Only little bit of opacities on the apex. This is a CT film showing majority of granular opacity in the major areas of the patient and especially on the basis. So most of the time we rely on the X-rays because CT scan it's again a tedious job because you need to shift the patient down to CT room. You have to hold the CT scan for the patients. Again, the chances of infecting other people always there. But whenever feasible, we get it done. But most of the time, it is the X-ray in which we rely. So besides the imaging, we have to rely on the clinical factors because that is the basic parameter which is always available to the patient. So most of the time, the saturation, the respiratory rate are being taken to assess the status of the patient or status of the disease. So the handy thing which is available is your oxygenation parameters. As per the world definition, as per the international definitions of AIIMS, they classified into three categories: mild, moderate, and severe AIIMS. So there is a ratio of PaO2 and FiO2. PaO2 is the partial pressure of oxygen in blood, which is detected by our ABG analyzer, and FiO2 is the fractional inspired oxygen concentration, how much the oxygen the patient is taking on. So depending on the PAF ratio, they are classified into three categories: mild, moderate, and severe. If the PF ratio is between 200 to 300, the category is mild. If the PF is between 100 to 200, moderate, and if it is less than 100, it is a severe. It is in the category of severe AIIMS. Now, many times in ward, ABG is not readily available, or the person, the doctors posted there may not be so trained, or many times it is very difficult to take the arterial blood gas sample, and patients even don't allow it to take it repeatedly because it is a painful procedure. So the thing which is available is your SpO2 probe. So you have monitors in all the wards, so you can just check the saturation of the patient. So the term has evolved with COVID is a fraction of SpO2 and FiO2. So FiO2 you can very well calculate with the amount of flow the oxygen is given, and saturation you can check it by pulse oximeter. So if you have the saturation and you know the FiO2, you can calculate the ratio, and if it is less than 315, then patient is an AIIMS. There is no need to classify the grade of AIIMS because by this time the patient is only in ward. So if you just find if it is less than 300, you send the patient to either SU or critical care unit. So most of the time, the patient who are in ward, they are either on oxygen mask or on non-rebreather mask. So here I have shown an image of non-rebreather mask. It has a reservoir bag in which the oxygen gets entrapped, and then the patient breathes in. There is a one-way valve, and plus there are valves which open up at the time of exhalation. So there is no mixing of gases at the time of exhalation. So suppose the patient is in ward who is having SpO2 of 90%. The saturation is 90%, and he is on non-rebreather mask at 15 liters flow. So whenever the flow is beyond 10 liters per minute, we presume that the oxygen which has been delivered is up 90%. You can even achieve up to 100% but at higher flows. But mostly if the flows are about 10 liters per minute, the amount of oxygen concentration which is delivered is 90% of it. If you talk in terms of FiO2, it is 0.9. So if you find a ratio of SpO2 with FiO2, 90 divided by 0.9 is 100. So definitely, if the patient in 15 liters flow on non-rebreather mask, maintaining a saturation of 90% only, his SpO2 FiO2 ratio is less than 300. So the patient is getting sick. He needs to be shifted to either SGU or to a critical care unit where he'll be managed accordingly. Now, we're going to clinical management, or I would say the drug management of the COVID patient or the ventilator management of the COVID patient. So the most of the time we find the patients more than 80%, 70-80% of the cases, they are either asymptomatic or they are in a mild category. So if the patient, they generally don't require hospitalization, if quarantine facility or isolation facility is available at the home, they are advised to stay at home. And if it's not feasible, like the person who is in hostel or it doesn't have enough facility at home, they are advised hospital admissions. And they are just given symptomatic treatment. If their fever is still persisting, they are given antibiotics to control the fever. And if they are sent back home, they are advised that stay at home, isolate yourself, take antibiotics for fever. And if you are having breathlessness or if your fever is persisting beyond 100 degree Fahrenheit, or if you are having fever beyond 101 degree Fahrenheit and is not subsiding with antibiotics, you have to report to hospital. So this is the advice which is given. They are sent back home. So besides this, there are certain high-risk category which may present you with mild illness, but since they fall in high-risk category, they have to be hospitalized and managed in the hospital. So the patients who are more than 60 years of age, patients have underlying comorbidities like hypertension, diabetes, or they are immunocompromised. They are on steroids or they are on drugs like methotrexate, cyclophosphamide for their underlying disease. So they are considered as immunocompromised. The patient of CKD, chronic, or patient of ILD, or patient of having any chronic lung illness, all these patients fall into high risk category. So they have to be under vigilant monitoring because they tend to deteriorate very rapidly, and you can't predict the course of illness. So they are advised hospital admissions. They kept under constant monitoring, and they are managed accordingly. So these patients have to monitor, their saturation has to be monitored. So pulse oximeter is used, and whenever the saturation falling below 84%, below 94%, on room air, the oxygen supplementation has to be. You can give it by nasal bronch, you can give it by face mask, or reserve bag if the requirement is high. Now the question is, what is the drug therapy which we have to advise or we have to prescribe to these patients? So I said that asymptomatic patients who is not into any risk category, no drug therapy has to be given. The patient with mild cases with maintaining saturation of more than 94%, you can just prescribe paracetamol. We can give them paracetamol to control temperature. Patients complaining of gastritis or discomfort, you can give them TBIs. And if the patient is having infectious cough, because this illness produces a lot of oral dryness, oropharyngeal dryness, so patient may have cough, or the patient can have both dry cough as well as cough is total production. So that has to be managed accordingly. Now to discuss about moderate cases. So patient whose respiratory rate is more than 24 breaths per minute, patient saturation is between 90 to 94% on your oxygen support, and patient can become hypotensive if the multisystem involvement is there, and or patient can become even delirious, or patient can go drowsy because of hypoxia. So the patient is having any of these symptoms, patient fall into moderate category. So they have to be given supplemental oxygen. And there is a concept called awake proning. So we ask the patient to lie in a prone position. They can keep the pillow below under the chest, and they are asked to be prone as much as possible. So they should be counseled to be in prone, because patients generally are not used to lie prone, or they are not used to be in this position, especially if the patient is very obese. So they have to be counseled, because the studies have shown that if the patient lies in prone position, it transiently improves your oxygen. Long-term effects are still yet to come. So it improves oxygenation, decreases oxygen requirement. So till date, we have only this data that proning helps in transient improvement of your oxygen levels. The drug remdesivir inhibits the process of translation. So we can give 200 mg loading dose followed by 100 mg OD. Earlier it was for 10 days for severe cases. For mild cases it was for 5 days, but these days because of the ongoing studies, the duration has been reduced to 5 days, including the first day of loading. Then few of the autopsy reports have shown that there is a process of microthrombosis or thromboembolism is going on. So the patients who are in moderate category of illness, they have to be kept on enoxaparin, that is low molecular weight heparin, and you have to monitor the D-dimer level. So the dose can be adjusted. So if you give a single daily dose, that is called as a prophylactic dose, if the D-dimers are rising, then you have to change them on the PT dose that is called therapeutic dose. So we have to decide depending on the condition of the patient and the values of D-dimers which you get from the lab. Steroids, earlier there was no for the steroid, but these days there's strength. So there is a trial called recovery trial in which they said that low dose steroid, if you give dexamethasone 0.1 milligram per kg per day, that is, if you consider a patient to be 60 kg, it is 6 milligram in village for 6 to 8 milligram per day, and methylprednisolone 1 to 2 or 0.5 to 1 milligram per kg per day is advised to prevent the ongoing inflammation. Besides this, you can give supplements like PPIs, vitamin C, multivitamins. So these drugs, nobody knows that whether they have a placebo effect or they are really working, because still we don't have enough data, but they have been we are prescribing these drugs regularly in the ward as well as in ICU. Now, with the advent of COVID infection, a new device that is high flow nasal oxygen or high flow nasal cannula has come into action. It was known from last 10 years, but it was not in so much of use. But with this COVID, there is rampant use of high flow nasal cannula. So this is a device in which there is a humidifier, there is a compressor in the chamber, and you attach the device to an oxygen source. So the advantage is that you get a very high flow. So normally this is a traditional or conventional your flow meter in which you have a flow regulator here, and you can see the flows, and you have a chamber to humidify the air. So the limitation of the device is maximum flow through which we can give is only 15 liters per minute. So that was the limitation. But when the patient is having any illness or pneumonia, the patient gets tachypneic, the minute ventilation increases. So it goes far beyond 15 liters. So the patient requirement goes up, and patients need to be given oxygen at high flow. So this device, you can start with 30 liters per minute and go as high as 60 liters per minute. And the oxygen range is 21% to up to 100% you can achieve with this. Nowadays, the ventilators they have also incorporated the mode of oxygen therapy in their ventilators, and you can give high flow nasal in the ventilators which are coming these days. Obviously, when you are giving the oxygen at such a high rate, so it may produce a dryness, which may cause discomfort to the patient. So they have to be humidified and heated. So this chamber humidifier attached will just heat up the air passing through it and humidifies it so that the patient is not discomforted, there is no crusting, and there is no drying of secretions. And when the flows are very high, it tend to produce a CPAP effect. So they help in recruitment of alveoli and washing of the carbon dioxide as well. And with this COVID, there is also an interesting term which has been introduced is happy hypoxia. So we have seen ourselves in an institute that people, their saturation goes down, but they don't become tachypneic. They are very much comfortable. So this was a patient who was in COVID ICU. So he classically fits into happy hypoxia. If you can see faintly, you can see it is somewhere around 94% saturation. He is on high flow. This is a device, nasal cannula is attached to it. So here he was a saturation 94%, and after some time it falls down. It got reduced to 81%, and then to 71%. Still there was no tachycardia. Pulse rate was still 88, 92, 76. So he was comfortable. He was not dyspneic. He was not tachycardic, and they tend to tolerate. So the patients who tolerate hypoxia very well because of their healthy lung condition, because of healthy lifestyle habits, so they do fairly well in COVID infection, and they come out very well. So there are 6 or 7 clinical parameters which we generally observe while managing these patients, because every time you cannot access, you can't send samples because it is painful as well as discomfort for the patient. So these are few clinical parameters which we normally overview. So they call it as early warning scores. So you have a respiratory rate, you have oxygen saturation, you need to monitor that whether any supplemental oxygen is going or not. You have to monitor the temperature, the systolic blood pressure, the heart rate, and the level of consciousness. So all these 7 parameters are clinical parameters which we can very well see in the ward. And the scores are graded from 0 to 3. 0 is minimum and 3 is the maximum. And then you divide at the number of into different grades as per the aggregate. If the score is between 1 to 4, patient falls in low risk category. If the patient score is 5 to 6, that is red zone, medium risk, and subsequently high risk. The most clinical or most significant finding which we see in the patient is the respiratory rate as well as the consciousness. The patient is having saturation around 85% on supplemental oxygen. If the patient is not taking the patient's respiratory rate is below 20. We don't panic. We just give time we give time to the patient to recover, and patient is fully conscious, awake, is comfortable at 85% of SpO2. We just keep monitoring the patient. But if the patient is getting tachypneic or the patient is getting delirious, then it is a worrisome thing. So these two parameters are clinical parameters which have to be looked into again and again while we are reassessing our patient, because they definitely affect the outcome of the patient. Now, beside this, the drugs, there are a few drugs which came into picture. They are using off-label. So one is convalescent plasma, because so much literature is available online. Every day we read in newspaper. So it is not the patient, it is the relatives who always come up with this query that whether my patient has received a plasma or not. So ICMR has started a classic trial. Now, still interim analysis is going on for this. So just to see that whether the convalescent plasma is benefiting a patient or not. So what is this convalescent plasma? Any patient who had a COVID infection, who was symptomatic with COVID, and he has recovered from that. And after 2 weeks, there are antibodies which start developing. So after 2 weeks of the recovery, normally a blood is taken out through plasma paralysis machine and they extract the plasma. It's just like fresh frozen plasma, but it is carrying IgG antibodies in that. And it is if we have a plasma, so we normally ask the relatives that if anybody in your family is found to be positive, was symptomatic and recovered, and 2 weeks have passed from his recovery, you can ask him to donate the blood so that your patient will be benefited. And from his blood, the plasma is extracted, and mostly 200 ml of single dose, or if you discuss in terms of per kg, it is 4 to 13 ml per kg. So 200 ml of single dose for adult is enough, and it has to be transfused slowly and can be repeated after 12 to 24 hours. But generally, plasma is not even beyond 2 doses. So we give single dose, and one more dose is repeated within 12 to 24 hours. And then further doses are not going to do any benefit. So 2 doses of convalescent plasma is into practice. And another drug is tocilizumab. As I said, that it is an IL-6. It is a monoclonal antibody, IL-6 antagonist. So whenever you have the laboratory parameters of interleukin-6, CRP, ferritin, the interleukin-6 normally it is less than 4 picogram per ml. It is rising more than 4 to 5 times. Looking at previous studies, we have kept a cutoff of 150 picogram. AIIMS Delhi, they have kept a cutoff of 100 picogram. So it's only a lab value. But the thing is, the clinical condition is the patient is in a moderate category and is having increasing oxygen requirement. You have taken him on high flow, started with 50 liters, 50%. Over next 12 to 24 hours, the oxygen requirement has gone up from 50% to 60, 80, 70, 80, or even higher. Or flow requirement has gone from 50 to 60. You need to rethink that patient is getting deteriorated, or if the patient is on mechanical ventilation, if FiO2 is going up. So you need to take a call that patient is getting deteriorated. So you have to give, and then depending on the condition. But again, the drug has its own drawbacks because it is IL-6 antagonist, and it prevents the cytokine storm. So there is always a risk of secondary infections. The bacterial infections may go up. Patient may develop neutropenia. If the patient had underlying tuberculosis, if the patient is not given you a history, there is strong risk that tuberculosis may flare up and you need to face up with another complication. So the relative has to be conscious that these drugs, they are not the wonder drugs. Not many things are available on the literature as well as in the newspaper, because tocilizumab is a costly drug. 400 milligram injection costs you around 40,000. So they are being used so people just understand that if they give, since it is an expensive drug, they give tocilizumab, the relatives should do well. So they have to be conscious that there are risks that secondary infections may flare up. Patient may develop neutropenia, or if the patient is carrying asymptomatic tuberculosis, or patient had tuberculosis in the past, it may even flare up. So that there are the drawbacks of these drugs. Now, when the patient becomes critically ill, the patient is in ICU. How to manage these patients? So initially, they are kept on your high flow nasal cannula or high flow nasal oxygen, but if they are bursting down, their oxygen requirement is going up, they are getting tachypneic, respiratory rate more than 40 per minute, 45 per minute, they are getting delirious, they have to be intubated because otherwise they'll go in respiratory failure and collapse down. So they go, so these patients are intubated and taken on ventilator. So when they are in ICU, we talk in terms of PF ratio. So it is a severe ARDS if it is less than 150 or less than 100, and if CO2 is going up and not able to maintain pH above 7.2, they have to be intubated. So as these patients, they don't have any reserve, so they tend to deoxygenate. As soon as you induce them, you paralyze them for intubation, they tend to deoxygenate. So you have to deoxygenate. So you always ask residents that don't remove their high flow, let them breathe on high flow, and supplementary you use the brain circuit or additional devices to give them oxygen. And you have to attach a viral filter whenever you're using any agent, because you have to prevent the spread of virus, because when you are intubating, you are very close to the patient's mouth, patient face. So although you are wearing a PPE, but you have to take additional precautions. Put in a viral filter between mask and the brain circuit, and you take them as anticipated difficult intubation, or if you can, because many times you don't get time to assess them. So if it is generally the rapid sequence intubation has to be followed, and they are advised to use video laryngoscope, because in video laryngoscope you don't go that close to the mouth. You insert a laryngoscope inside the oral cavity, and there is a screen which is away from the patient, and you can see the oral cavity and the vocal cord on the screen. So you don't have to really go very close to the patient. Moreover, the view also improves with use of CMAC and other video laryngoscopes. So they can be used. Different induction agent, propofol, ketomidine, or ketamine can be used. You can use muscle relaxant, and then once the patient is intubated. And one more thing is that as you introduce the tube inside the trachea, so there are chances that secretions, the pooled secretions, which may even come out. So you have to clamp the tube. So ETT, endotracheal tube clamping, is an important step while doing an endotracheal intubation. So whenever you intubate, you clamp the tube, and as soon as the tube passes the vocal cord, endotracheal tube clamp has to be removed and ventilator circuit is connected. So this is a classical table taken from ARDS net protocol. Right? So they have given a relation with FiO2 and amount of PEEP. So as FiO2 is going up, the PEEP is also going up. So this is good when the patient's compliance is low. But looking at this table, many times the resident doctors, because they keep changing, the new workforce is coming in. So looking at this ARDS net table, they tend to give too much of PEEP to this patient. So they need PEEP, but you need to understand the compliance. But in general, they need higher oxygen delivery, higher FiO2 as compared to PEEP. So mostly the patients are kept at PEEP of 10 to 12 centimeter of water, even though your FiO2 is going up. So you need to see that if compliance is changing or not. So the term called driving pressure has come into picture. It is a difference between your plateau pressure and PEEP. So if you don't have understanding of these complex terms, you need not to worry about that. If you're posted in ICU, CCU, just keep a PEEP of 10 to 12, and you can go up with oxygen up to 1 or FiO2 1, oxygen of 100% till you get all these nitty-gritties of ventilation. And you said about sorry about that technical glitch. So, treatment of co-infections. So, used to give empirical antibiotics depending on the infection protocol of the institute. And as soon as the patients are intubated, we send cultures, endotracheal cultures, or blood cultures, and then we decide once the cultures are available. And this is all about ventilation. You need to give low tidal volume ventilation, 4 to 8 mL per kg of predicted body weight. You have to keep plateau pressure less than 30 centimeters, and little bit of hypercapnia is permitted, because if the ARDS is worsening, you go on concept of low tidal volume ventilation. So in this condition, your CO2 may go up. So permissive hypercapnia is is allowed, and as long as your pH is above 7.2. And patients may require deep sedation. At times, you need to paralyze the patient because if you need to own this patient, you have to paralyze this patient. And whenever you make them supine from groaning, you need to do a sedation vacation to assess the neurological stages, which is very important because the patient are prothrombotic, they have hypercoagulability. So there are chances that patient may develop infarct, so you need to assess their CNS, or the patient on diabetic. So it's found that patient have blood when they are on ventilator. So you need to assess the CNS daily so that if there is any complication, you can intervene and solve it. So this was about your phone ventilation. Now coming towards the discharge policy. So CDC was the one who devised the discharge. Initially, they said it could be a test-based or non-test-based. But then over a period of the last 2 months, there are a lot many updates which have come on CDC. So recent update which they have released on July 17, they said that a test-based strategy is no longer recommended because in majority of cases it results in prolonged isolation of patients who continue to shed a detectable virus, but they are no longer infectious. So now CDC is also moving towards a non-test-based discharge policy, but they said that the patient who had mild to moderate illness and who are not severely immunocompromised, so at least 10 days should have elapsed if they are in hospital. They have to be kept 10 days since the first symptoms have appeared. And initially it was 3 days or 72 hours. Now they are switched over to 24 hours. That if they are apprevalent from past 24 hours, they can be sent back home with the advice that they have to isolate themselves from other people for next 7 days. And patients who are severely ill, who are in ICUs or who are severely immunocompromised, so they have to be kept in hospital for at least 20 days since the first symptoms have appeared, and if they are apprevalent for 24 hours, if there is resolution of symptoms, that is initially it was only respiratory symptoms, they have include other symptoms also, so they can be discharged back home. So this is a modification which they have released on 17 July. They said that they have changed from 70 they have changed the period of afebrile phase from 72 hours to 24 hours, and they have changed it from improvement in respiratory symptom to improvement in symptoms because they are myriad of symptoms in which the patient presents. These are two recent updates which CDC has posted on their website. So this is a discharge policy of our institute. We are following MOHFW guidelines. So till now they are not updated. So we are still following these guidelines. So the criteria which we keep is that there has to be resolution of fever from last 3 days. And if the patient is under mild and moderate category, there is no need of test. They can be discharged by home. The patient is on severe category, then they have to be tested. And moreover, it is discretion of clinician as well as the nodal officer and the laboratory team. We take a joint decision whether we have to test or what policy. But as the rule which we are following is the patient has to be afebrile without antibiotics for 3 days and at least 10 days have evolved from onset of symptoms to the discharge. Okay. Thank you all of you for being connected to us. Now, we have a panel of experts in which we have Bhatia sir, we have Dr. Ankur and Garg sir. So all of you can ask questions. So I'll moderate the questions and they are the experts of this field. So they'll address your questions. So I'll ask them to please come. Ankur. So people ask lot many queries. So first question which I would like to take is by Dr. Daisy. So she has just thanked everyone. Okay, thank you, Dr. Daisy. And Dr. Puranik, they have asked about beta interferon. So he said that I believe that beta interferon has best results preventing 70% mortality. So any sir comment on that about beta interferon? Solidarity trial.
Yeah, it is still a part of solidarity trial conducted by WHO. It is a multi-center trial, and our institute is also a part of this WHO-sponsored trial. The studies are going on. There are no recommendations. There may be a few papers here and there, but they are not part of the standard protocol anywhere in the world.
I agree with Dr. Bhatia that the literature, there is very few literature available about the interferon beta, and these are also anti-inflammatory drugs. So anything which acts on the inflammations, almost all over the world, everything is being tried to inhibit the inflammations. So this was the part of the
Transient symptomatic relief.
Yeah, so transient symptomatic relief. And as to the solitary trial, we have given the data. The results are still not out. So we can't say these are experimental drugs. That's all we can say.
Okay. So Dr. Puranik is also have another query that do we have any data on VAP, that is ventilator associated pneumonia and cultures of our intubated patients. So I would like to, we are still compiling the data. So we are sending the culture regularly. So we need to compile it and probably present it. I would like to request Bhatia sir to give a comment on that.
Yeah, ventilator associated pneumonia is a common complications in the patients who are managed in ventilators, and the data varies from center to center. It depends how much precautions do you take in preventing the silent aspirations and the thorophysiotherapy is done. Well, I would say, though there are no data, but I would say that there is a possibility that the chances of that may be slightly on the higher side than the other patient population, because most of the healthcare workers may be a bit worried and would not like to get exposed to the routine physiotherapy and care of the patient as they are doing in the non-COVID patients. So there is a possibility, though we don't have a data, but then the risk of VAP will be definitely there in the patients who are kept on ventilator.
So basically, anybody is on the ventilator for more than 48 hours, chances of VAP always increases. And moreover, it is very difficult to detect in these cases because they are already having the underlying lung conditions. Those who are normal adults, and if they develop the VAP, we can detect it by clinically or radiologically. But here the patient is already having the lung conditions underlying. So to detect them is not possible. That's why you have seen that we are trying to use the empirical antibiotic therapy in all the patients. And definitely VAP, and moreover, if you use the tocilizumab, the chances of secondary infection will be much more. So that's why we are using the empirical antibiotic therapy according to the community-acquired pneumonia or the healthcare associated.
Other question by is there analysis of patient treated at our center, outcome analysis? So I would like to add on that for ICU till date from May to July, we got 114 patients in ICU, and out of that 47, we couldn't say 47 patients, so 47 deaths are there from May to there, and 114 patients. And overall, we have analyzed our institute also data. So Bhatia sir can add on to that.
So the mortality data is as good or as bad as any other good center in the world. So you may label it bad outcome or good outcome, whatever. Then 40% mortality rate is there established in most of the centers, and we have the similar mortality rates.
Basically, we have analyzed the data, and at present, admitted patients we have the 5% mortality, and the ICU patient, including the HDU as well as the CCU, if we both combine, we have the 20% mortality, and which is on the lower side of the all over the world. Data at present today indicate 20 to 50%, and all over the world, anybody on the oxygen is considered as a severe and part of the CCU. Here we have the HDU and CCU. What Dr. Bhatia was telling about the only CCU. If we combine the data of the HDU and CCU, our mortality stands around 20%, and overall mortality is 5%, and which is among the lowest in the world.
Yes, because till date we have admitted and managed more than 1,000 patients who are positive, and out of that we 140 patients went into ICU, and out of those 47 patients saved. So So, Dr. Devda, so Dr. Srin Devda has asked that, is there any role of spirometer in COVID management? Yes. So, yes, we are regularly advising the patient to respiratory exercise. So, it is basically the respiratory exercises we are giving them the acapella, which is a PEP device, in which the patient has to exhale out through the device and it produces vibration. So, it helps in coughing out the secretion, and patients, we are giving them spirometer. So, they are doing it regularly, and these are all breathing exercises which increases your vagal capacity and your oxygenation. So that we are giving them. And I would like to ask our experts if anybody would like to add anything on that.
As far as the spirometer is concerned, still long-term sequences of the COVID-19 we do not know. With the MERS and SARS, long-term fibrosis has been reported, and the decrease in the PFT has been reported with those two conditions. Here we have started to still see the long-term effects of the COVID-19. As of today, when patient comes out of the ventilator, they goes onto the oxygen, high flow, then nasal, and then once they become asymptomatic, I don't think there's a much role of the spirometer unless until we know what is the long-term outcome and whether it is going to prevent fibrosis or long-term sequelae. We have no data and I have no experience whatsoever. As of today, in HDU, we are not using the spirometer. About the CCU, because patient is the high flow ventilation, NIV or ventilator. So I think there is no scope of using spirometer. And mild cases usually recover automatically. So it is spirometer where the long-term effect will be there or not. I can't say it. I will ask Dr. Bhatia if he has any experience.
Yes, spirometry can help in improving the lung capacity. But see, the most important thing in the initial period is to get rid of the infection and inflammation and the respiratory tract. So it can be done if the patient is comfortable doing these things. But then probably it will go useful in the recovery phase. And the patient is improving and then he does all the exercises. But yes, there is no contraindication, but there are no proven benefit, at least in the earlier stage. That's what I have to say.
Okay. So another question is, Dr. Negi is taking that question. So he has asked that, what is the cutoff level of D-dimer for giving a PD dose, that is therapeutic dose of nasal? I just want to know what is the cutoff level of D-dimer.
So basically, as far as the recommendation goes, the therapeutic dose is only to be given when you have the clinically well-documented thrombosis, either in the form of the DVT or VDE or PE. So before that, D-dimer only is, you cannot take it as a cutoff points. So if the patient is walking around, like in the HDU patient is walking around and is mobile, we give the prophylactic dose is, I think, more than sufficient. Only once you have the documented thrombosis or embolism, then only therapeutic, anticoagulants are advised. Not only D-dimer should not be the indicator of using therapeutic dose. This is my opinion. And I will ask Dr. Bhatia, because we differ both in this area and we usually discuss in our evening rounds. So we have the both difference of the opinion. But as far as the ICMR and MOHFW guidelines, they say that that patient with the high risk always should be given the prophylactic dose of the D-dimer, and all the moderate cases and therapeutic dose to be given only when there is a evidence of the thromboembolism. Dr. Bhatia, please.
Yeah, I agree that we have some difference of opinion regarding the therapeutic use and even prophylactic use of enoxaparin. The specificity of D-dimer in diagnosing thrombus and embolism is not very high. But in these cases, when the other factors like trauma or surgery is not there, D-dimer can be used as an indicator of thrombus generation first. Secondly, most of the time there is microvascular thrombosis in the lungs, which are not easily picked up even by pulmonary CT angio. So we have got some patients this CT angio, but microvascular thrombosis may not be detected easily. We are planning for some EQ scanning in these patients. Literature suggests that it should be given whenever D-dimer increases because it is often associated with hypoxia, increasing hypoxia. But the reason why I am in favor of giving therapeutic dose of enoxaparin in such patient is that most of the time the lungs are compliant. A patient easily takes a large steady volume breath. So in compliant lungs, why should there be hypoxia? And the most easy and commonsensical explanation would be there is a microvascular thrombosis which causes the hypoxia in this patient because there is no uptake of oxygen from alveoli to the vascular bed. So if this oxidation worsens and the D dimer increases from 2 to 3 times of the base value, yes, we do start therapeutic dose of enoxaparin.
One more thing is, whenever we give the anticoagulant, always remember the underlying risk of the bleeding. So we have the Hasplate score, and if it is more than 3, always use cautiously because our treatment should not harm anybody. So we always take care that whether patient is in a high prone to the bleeding, then probably we will not use anticoagulant or use in the lower dose. Like underlying CKD patients, you have to decrease the dose. So you have to consider individually each patient. You cannot make the statement bluntly that all patients should be given because it is a double-edged sword. It can do good, it can do bad. So you have to take the patients into consideration before we give any anticoagulant. I will ask comment from them.
Yes, ma'am. If the patient is not intubated, we are using prophylactic dose, that is OD dose. And if the patient is intubated, we are using a BD dose, that is the therapeutic dose. We are using this in COVID-19.
Yes, so this is very valid point which I could have stressed on because you need to think of purpose side also. So stasis is also one of the parameters because if you have a mobile patient, as Sir is saying, Sir has said that the patient is moving around, patient is mobile. So there is less chance of stasis. So you can be dealing with OD dose or correct dose. But on the contrary, as Sir has said that the D-dimer are going up, patient is intubated on ventilator. So patient is not moving around. So always stasis is a component which may add on to ongoing thrombosis. So need to say, so it is a case-to-case basis that what type of patient you are dealing with, you can go with prophylactic as well as therapeutic dose. So that is in continuation of thromboprophylaxis. Professor Jha has asked that any change in bleeding parameters. So have you observed that is there any change in bleeding parameters? Because initially few of our patients, when they were on heparin, they have blood, they have intermittent bleed. So I would like to ask the expert that is there any change in bleeding you're seeing these days?
Yes, our study is going on about the assessment of the coagulation parameters in the COVID patients. As reported by the other countries, there is in the this D-dimer level, there is an increase in the factor 4 or factor 8 levels, increase in the fibrinogen level. But what in our study in AIIMS, we found there was the decrease in the vitamin, antithrombin C and S levels, which was quite different from what has been other reported. So at present, we are finding that there is the thrombotic episodes, plus there is the antithrombin levels are also going down. So, and as reports are also there that there is an increase in the fibrinolysis in the world. So one side you are developing thrombosis, another side you are developing the fibrinolysis. So if there is more of the fibrinolysis, you give the anticoagulant, you are increasing the bleeding tendency. So this area is totally gray, and more and more studies are coming out. And let us see, our own data, we have already things, and probably we are going to analyze in the next 7 days, and we will be able to give our own Indian Jodhpur data in the next 7 days.
So another question, I'll take it by Dr. Alok Sharma. So he has queried that are we still giving azithromycin or hydroxychloroquine to the patient?
No. Fully stop.
Even the celebrity trial has they stopped use of hydroxychloroquine. There is no other stop using. There is a question queried by Saurabh Jain, probably a resident or a student. So he asked that for patients with underlying chronic lung disease with baseline SpO2 of less than 94%, with more respiratory distress, what is the criteria of hospital admission?
Look, as far as the ICMR criteria, we are not discriminating that whether this patient is in underlying chronic lung disease, ILD, CKD, heart disease, anything. As on our flu screening test has been told, one clear-cut point, if it is less than 94%, they will admit it to the MICU, and then there the physician will see and decide whether it is because of the COVID or because of the underlying condition. So at the fluid screening desk, there is no discrimination. Once they are inside, the physician or the respective specialist see, and then he can decide whether it is because of the COVID or underlying condition. We have seen the patient of the COVID who are recovering, they have become negative, but the SpO2 is still 90 to 93%, where the discharge criteria says that without oxygen, they should be discharged. But in that condition, we have to take the underlying condition like ILD, COPD, and there if the patient is asymptomatic, afebrile, RT-PCR negative, and even the SpO2 is less than 94, we make the decision to discharge them with regular medical treatment of the underlying condition.
Yeah, less than 94% means they are moderately sick patients. It is indicated to be admitted, but then the patient is of chronic lung disease, they are at a high risk of developing complications. So the indications becomes even much more.
Still, we have not many questions. The last question is asked by Dr. Sierra. He is asking that the role of NIV, like the recently used in CHC, non-invasive ventilation, what is there any role? So I would like to ask.
People are trying NIVs. It is not our first choice, and this high flow nasal oxygen is more widespread use because it helps in oxygenation. NIV is more used for cardiogenic pulmonary edema and acute and chronic respiratory failure. But yes, people are using NIV in this COVID respiratory failure also.
So, good.
Yes. We are using HFNO in place of CPAP, and we are getting very good results because it supplements up to 100% oxygen, and the trials of NIV are very well, and HFNO is full-proofing in recovering the patients.
Actually, yes, I would also agree with this concern because high flow, the patient minute ventilation goes up, so they generally become very high flow. So, though you can achieve it with NIV, but it is claustrophobic. Patients don't tolerate well. But if you put on a high flow nasal cannula, it's just like any other nasal cannula. So patient accepts it very well, and they are more comfortable. It's only about you giving them oxygen at very high concentration. So they really do well, and you try to save them from ventilation.
Yes, one big question and probably last questions. We totally agree with the Dr. Kishan that remdesivir, only one trial, preliminary with data, then they saw only the decrease in the duration of viral shedding, probably by 15 to 11 days, and there is no mortality benefit. Here we are faced with the dilemma because there is no, as Dr. Nikhil has told, there is no other proven treatment, and we all are in the dark. And that is, this drug is at least not harmful to the individual. That is the most important part. All other drugs, they can harm the body, but this remdesivir is the viral RNA polymerase inhibitor. It does not inhibit the human RNA polymerase. Hence, it is only effective against virus and have the very least side effect to the human being or the patient. And that's why this drug has been rampantly used. And I agree that still we are in the dark and the studies are going on, and there is no double-blind placebo-controlled trial of the remdesivir. But face to the wall, people are using it. And we hope that in the near future, as the other trials will come up and we will get the definite answer, including the solidarity trial where we have used the remdesivir.
So with this last remark, I would like to conclude. So we have this remark from Dr. Nikhil because we have been discussing with her again and again about this problem. He said that IL-6 is a very labile analyte, and the sample has to be sent in a yellow cap bacteria because most of the time people are sending either yellow or red because both of them can be used. But they are seeing that if you're sending in red, falsely high values are coming up. So say specifically stress on that all those who are collecting the samples, all those who are in the ward, they should send the samples for IL-6 in the yellow cap bacteria to prevent falsely high values on this. So that was one thing I would like to mention. And I would like to thank everyone for being with us for 1 hour, and it's a very good participation. And I would also like to thank our experts and the directors who are here for our motivation and sorting out the queries of the people. Thank you very much.